This lecture will cover bioeffects and ultrasound. So as with any medical intervention, it's important that we study how that intervention affects the human body. So with bioeffects of ultrasound, it's going to be studied pretty in depth by scientists and other engineers, people that make our ultrasound machines. But as clinical sonographers, we're not going to have to do that much in the study of bioeffects. The bioeffects of ultrasound are really more significant with lithotripsy and therapeutic ultrasound, as they use really high levels of ultrasound, more than we use for imaging, and those might have a higher likelihood of actually causing bioeffects in the body. On the opposite side of that, though, with diagnostic ultrasound, the type that we use to create anatomical images, there's actually a very low likelihood that we'll be producing any harmful effects. But we're still using these on babies, we're still using these on human tissue, so we need to be able to monitor and kind of see what could happen if we could actually produce bioeffects. So with that, it's very important as a sonographer to understand the output of the ultrasound system. We have talked about ALARA in the past, and it is also important to know how certain settings are going to affect that MI and TI using the power system, and we'll kind of get into that a little bit more in this lecture and how it relates to bioeffects. So the main part of studying bioeffects of ultrasound is to know the intensities and the energy that is coming out of that ultrasound beam. So there are 6 devices that we use to do that. And we have the hydrophone, radiation force balance, acoustic optics, colorimeter, thermocouple, and liquid crystals. You're going to want to know all 6 of these, and we'll go over each of them in a little bit more detail. So a hydrophone, which is also known as a microprobe, is probably the most common way that we're going to test our ultrasound beam. There are 2 ways to make a hydrophone. The first one is a small hollow needle. It's going to have a piezoelectric crystal right at the end, very small one, 1 millimeter or less. Or the other way to make the hydrophone is to have this large PCT membrane, which kind of looks like it's made out of almost like a plastic wrap. And it's going to have these small metallic electrodes that are centered on both sides within this PCT membrane. And then either variation is then attached to an oscilloscope. The oscilloscope is then going to display the acoustic signal that's received by that crystal. And from that, we can record acoustic pressures at specific regions of the sound beam. If we move the hydrophone, then we're going to get different information back. As we look at that sound beam, we can then determine the amplitude, period, pulse duration, PRP, and PRF of the ultrasound beam, and we can actually also see the shape of the beam with the hydrophone. And with this, if we have a well-calibrated hydrophone, then we can determine what the intensities and other output measures are of the ultrasound beam. So here are 2 examples of hydrophones. The one on the left is the hollow needle version, and the one on the right is the membrane version with the 2 electrodes. You can see that looping green on that PZT membrane. So then these would be attached back to an oscilloscope, and the needle or the membrane then would be placed within the plane of the transducer, so it could then measure different areas of that ultrasound beam. Another way for us to test the ultrasound beam is the radiation force balance, and the idea behind this is that the incident sound wave can actually exert some force upon a small object that it strikes, and that goes back to mechanical index. It goes back to cavitation a little bit, and we'll again talk about that a little bit more later in this lecture. But the idea is that there's pressure energy in that sound beam. As it hits things, it will actually move something. So the construction of the radiation force balance machine is that there's a small ball or object that is placed within the ultrasound beam, and then the sound is directed towards that object, and the machine is going to measure the movement and force of that small object. It's going to be probably negligible to the eye, so it's a very small scale and the machine is very sensitive to that movement, but it actually is measurable. So there's a few different ways that we can use the radiation force balance to check on the intensities that are coming out of the ultrasound machine. If the ball is in balance mode, then we're going to measure the SATA, or if we put the ball in float mode, we are also going to measure the SATA. However, if the ball is suspended in air or suspended in a medium, then we're actually going to be able to measure the SPTA. So it's going to be important to know which mode measures which intensity on this one. The third way that we take a look at ultrasound pressure and intensities is acoustic optics. And the idea behind that is that there is actually an interaction of sound and light when they interact with one another. And the shadowing system is called a shielding, and because of that we can kind of see a shadow of the sound beam. So kind of interesting, not used probably as commonly to test ultrasound intensities, but this is the transducer face up here, and we can see the ultrasound beam coming out to the focal point and then diverging out at the far field. So it's actually very interesting. We can then see the beam's width and we can see the beam's axial resolution in this. So in this instance, the axial resolution is 1.8 millimeters and the beam width is 0.5 millimeters. So if we remember back to our earlier lessons about axial resolution and lateral resolution, objects would have to be at least 1.8 millimeters apart to be displayed as two separate objects in the axial plane. And for this one, objects would need to be at least half a millimeter apart in the lateral plane. So kind of interesting that we can actually see that beam profile. The next few methods that we'll talk about are going to talk about machines that test the absorption rate of energy. So a very common one that is used to understand absorption and heat transfer is the calorimeter. And so this is going to measure the total power in a sound beam by observing absorption. The calorimeter is set into the ultrasound beam, and again it's going to measure the total power of the entire beam, and it's going to recognize how much energy is going in and how much heat is being transferred, and that's going to help to measure that power. The more heat, more power in that beam. So again, with this one, it's going to be, remember, it tests the power of the entire beam, the calorimeter. Similar to the calorimeter is the thermocouple, and this is going to be a tiny electronic thermometer, and this is also placed into the beam and tests for absorption out of the sound beam. The difference, though, is that this is only going to measure power at a particular point within the beam. So the thermocouple can be moved up and down throughout the beam, and we can test different intensities throughout it, where the calorimeter tested the whole beam power. So remember those differences. It's important to remember each of those pieces as they relate to the device. The last type of device that we can use to measure the power or temperature, the intensity of the ultrasound beam are liquid crystals. So with these, there are special liquid crystals that are placed into the ultrasound beam, and this is pretty more of a generalized reaction to the sound beam, and it just gives kind of insight to how energy changes into heat. If you've ever seen a mood ring, when you put it on your body, it changes from different colors, from black as being cold to like red, yellow, green, and then blue is really warm. So kind of the same idea. If the crystals only change to red, then we know it's not a very intense beam. If they turned all the way to blue, then we would know that it's a little bit more intense beam. It's creating more heat within that ultrasound beam. So liquid crystals are going to just give us kind of a general idea how intense the ultrasound beam is. So it's important to understand as caregivers, when we are making medical decisions, or rather when the doctors are making medical decisions, are we going to provide a benefit with the decision that we've made? So we do the risk-benefit relationship, and we want to know that the benefits are going to outweigh the risks whenever we make a decision regarding somebody else's life. So when we think about X-ray, we know that it's radiation, and we know that that causes cellular damage and can cause cancer later in life if you're exposed to too much X-ray. So as doctors, they need to decide, is knowing that this person has a broken leg more important than the small chance that they might get cancer at a later point because of being exposed to X-rays? And typically, yes, the answer is yes, we want to know that they have a broken leg. We use X-rays sparingly. We use medications that can cause damage sparingly. It's all about balancing it out and knowing in the end that the benefits outweigh the risk. But we have to figure out how do we know that the benefits are going to outweigh the risks? And with that, there are lots of studies that are done to determine that. So we have in vivo and in vitro studies, and these are in the ultrasound realm here. We're studying bioeffects of ultrasound, and in vivo means to do within the living body. This can mean within lab rats or mice, something that is living. Humans also are in vivo test subjects. For the most part, in vivo studies are probably a little bit more limited. There aren't very many people that are like, yeah, see if you can kill me. That'd be awesome. So in vivo studies are usually only done once something is proven to be relatively safe, and we're just trying to figure out what the true effects of this medicine or intervention might be on the human body. The opposite of that then is in vitro, and this is going to be outside the living body. And oftentimes this is done by computer modeling from minimal things that we see with in vivo studies. As far as ultrasound bioeffects go, in vitro studies have indicated that with very, very high intensities of ultrasound beams, we can actually cause genetic damage and cell death. So we know that ultrasound has potential to do damage, which is why we need to be very judicious with our use of it. But the reality is the intensities that we're using for our diagnostic imaging are going to cause none to very minimal bioeffects. So we know that we can do in vivo living tests, or we can do in vitro outside of the body tests. Another type of study techniques that we look at for these studies are the mechanistic approach or the empirical approach. So the mechanistic approach says that there must be some sort of relationship between cause and effect, and that's what it's searching for. We're looking for that cause and effect. We've proposed that there is some sort of mechanism that could cause bioeffects, and now we are going to analyze and perform different tests to try to prove it. The empirical approach searches for the relationship between exposure and response. So this is kind of a past approach. The exposure has already been done, and now we're trying to find out, was there any sort of reaction to it? So this is going to be based more on acquisition and review of information from patients or animals that have been exposed to ultrasound. And the research is going to seek some sort of relationship, again, between that exposure and what may have happened later because of that exposure. So with this one, if you think about, there was a drug that was given to moms in the 70s that was to help out with morning sickness. And they found out in the end that a lot of those children were born with shortened, very short or non-existent humerus bones. And so that was more of a cause and effect. We saw that moms were given this drug, they thought it was safe, and then 9 months later they were giving birth to these children with birth defects. And so they did the empirical approach and saw that there was a relationship between exposure and a poor outcome later. So that's the empirical approach, looking at things that have already happened. So the question is then, what's better for studying ultrasound bioeffects? And the answer really is that they both are going to have their positives and negatives. You can introduce bias into both studies. You can miss correlations. You can make up correlations between certain things. So they really do both have their positives and negatives. It's really best when they both align. Your hypothesis is proved with exposure testing. So that's when they both align. So what are we looking for when we are running these tests and studies? Well, we're looking for two mechanisms of bioeffects, and we have figured out that the machine can cause heating within the tissue, so we look for thermal bioeffects. And the other thing that we look for is cavitation or non-thermal mechanism. And this is going to be radiation force and how the sound wave is going to interact with little itty-bitty bubbles that kind of ride around in our tissue. So thermal and mechanical mechanisms of bioeffects. Again, we monitor both of these with TI and MI, mechanical and thermal indices, on our machine. So first we'll talk about the thermal mechanism. There's two rationales behind the fact that we know ultrasound can cause heat to be created or increased within the tissue. As we've seen with the calorimeter and the thermocouple and those liquid crystals, we can test and see, physically measure that there is heat within the intensities. So two rationales behind thermal mechanism. We know that sound propagates into the body and that energy is converted to heat. The other idea is that our body core temperature is pretty well regulated at about 37 degrees, 98.6 degrees Fahrenheit. And we know that for a life process to go on within our body, we kind of have to be at that stable core temperature. If we alter that, go too low, or start increasing that, life processes aren't going to function the same way as they should at that normal temperature. So amino acids start to unwind, tissue damage starts to happen when we get too hot. So we know that there is a reason that we're at 37 degrees Celsius, and that is what the body should try to stay at. So we watch for tissue heating by monitoring the thermal index, which is labeled as TI on your machine, and this is going to calculate the number that is a useful predictor of the maximum temperature increase under most clinically relevant conditions. So basically it's saying the more power we're putting into the body, the higher the thermal index is, because the more chance that the tissue is going to be heating under that higher power. Thermal index can be broken down and reported into three forms. We have TIS, which is the soft tissue thermal index. We have TIB, which is bone thermal index, and TIC, cranial bone thermal index. What all three of these are saying is that the tissues in our body are going to react differently and heat at different rates than other parts of the body. So TIS is probably what we use most often, and this is just calculated assuming that the sound beam is only traveling in the soft tissue. That's typically what is displayed on our machine. TIB is the calculation assuming that the bone is at the beam's focus, so think of arms, legs, that kind of stuff, that most intense part is right at the focus, and that's what is being hit by the ultrasound beam. This is actually going to be a little bit higher than the TIS because bone and soft tissue interfaces actually heat up quite a bit. The most accurate thermal index monitoring is at the cranial bone, and that is because it's very near the skin surface, and again is in that interface of skin and bone where we're going to see most of that heating occur. All three versions are the best measurements for in vivo tissue temperature elevation. So we're so concerned about the tissue and bone interface because bone is an absorber. As that sound goes into the body, we don't see anything past it because of attenuation, but a lot of it has to do with the fact that the bones absorbed most of the sound energy. So the more that it absorbs, the more likely it is to heat up and convert that energy into heat. So temperature elevation is more likely at that tissue-bone interface. It's a big consideration when we are doing fetal ultrasounds because the fetus in the younger stages is completely enveloped in the ultrasound beam. So we need to be very considerate of the power that we're using when we're imaging fetuses. The thermal index all has to do with the SPTA intensity, as that is what is related to maximal heating, the most intensity that's coming out of that ultrasound beam. In studies, we have found that there is no known bioeffects if we only get a 2 °C change in the tissue temperature. But after we get past that 2 degrees, we have found that even a 2 to 4 degree increase in testicular temperature can result in infertility. And there's actually numerous defects that are documented in fetuses from some sort of temperature rise. But again, that has not been proven unless temperatures have risen above that 39 or 2 degrees higher than what our core temperature is. So with TI, we want to reduce it, especially when we're imaging fetuses or are near any tissue-bone interfaces that are going to be more likely to heat up. So the other mechanism of bioeffects is cavitation, or the mechanical part of it. And we've already kind of talked about mechanical index and how it relates to microbubbles. And this is going to be kind of the same idea, except that we're not actually introducing in microbubbles into the body as a contrast. We just need to recognize that there are actually microbubbles, or gaseous nuclei, throughout the body. You're just going to have tiny itty-bitty little bubbles or little air pockets throughout the body. And as sound beam hits them, they're going to react the same way as our contrast bubbles are, in that they're going to start to expand and shrink. They're kind of excited by the ultrasound beam. And so the idea is that as the ultrasound beam hits these naturally occurring little bubbles, that they're going to react to it, and if they were to pop, that they could actually do damage to cells around them. So it's important, again, that we are using low mechanical index because we want those cells to not expand and contract to the point of bursting, but we're okay with kind of a lower undulating process. As we remember, very low MIs just kind of cause a slight change in the bubbles formation, but does not cause them to burst. So MI then is related to that radiation force. Remember, we know that ultrasound machines can cause pressure, which will cause movement within tissue, and we know that it may distort or disrupt the tissue that it is encountering. And again, that's all due to that cavitation, which is the interaction of sound on gas bubbles. And we also know that's related directly to that MI. Lower MIs are going to cause a stable cavitation where it's just more of an oscillating bubble, not bursting, where high MIs are going to cause transient cavitation, which is going to cause the bursting of those bubbles and possible tissue damage. So remember, mechanical index should always be kept as low as possible. So now that we have all these tests that are done and we've taken into the considerations of mechanical and thermal indices, and we've tested our ultrasound beam for intensities, and we've looked at how it affects bioeffects, the people who actually study the bioeffects of certain interventions or medicines or exposure type stuff are epidemiologists. So we need to understand kind of how the epidemiology plays into the study of bioeffects. So epidemiology really is a branch of medicine that is associated with population studies. More often than not, epidemiologists are going to be using empirical studies. And as far as ultrasound goes, a lot of them are going to deal with in utero fetal exposure to ultrasound. And that's going to be that we know this set of babies were exposed to ultrasound. Do they have any birth defects because of it? They're going to try to find some sort of correlation. When that is the case, if they're trying to go back through medical records and trying to correlate something, we consider those to be retrospective tests because they're looking at charts and information that have been acquired in the past. There are problems with epidemiology studies in that there are some ambiguities. we don't know what the justification for the exams were. We don't know necessarily what the gestational age and how that affects things, how many exams the fetus was exposed to, and were all considerations taken in as far as thermal and mechanical index and that kind of stuff. So there's just things that we don't know about the situation, as every clinic is going to have different machines, different presets that are going to change the power output, that kind of stuff. The other problem with epidemiology studies is that the risk factors may be different. All the moms are going to have different ages. They're going to have had different nutrition, different other exposures. Are these babies showing up with birth defects because of ultrasound, or are they showing up with birth defects because of some sort of alcohol or drug use during the pregnancy? So there are limitations on epidemiology studies, but they're still important to assess, is ultrasound causing issues later? So one way to try to get around the issues of the retrospective study is to try to do a prospective study, which is actually going to be looking forward, testing a hypothesis. And in these cases, the data is systematically obtained. So we're going to have one ultrasound tech with one machine performing the same exam on a set of people. That's going to give better data in the sense that we are not introducing all those other exposure things that we may not know about from those retrospective studies. We're really building the study as we want it. When we get to build studies, another thing that epidemiologists try to do are to do randomized studies. Typically there are two groups of patients. You have your control group, which is not exposed to ultrasound in this case, and then you have your other group that is exposed to ultrasound. So then you can compare the two. Was there any sort of significant difference between the moms who had ultrasounds versus the moms who did not have ultrasounds? In the end, most of the studies that have been done and analyzed have shown that there is no associated adverse fetal outcomes with ultrasound, and really no adverse outcomes with any sort of ultrasound use in the diagnostic form. So the American Institute of Ultrasound in Medicine, or the AIUM, puts out a lot of studies regarding our profession and has a lot of opinions and suggestions for our profession to kind of base a lot of our work off of. So this was conclusions regarding ultrasounds in obstetric use. And basically what it said was there were some studies that said, yeah, there's issues when you use ultrasound, and there's some studies that say, nope, no issues when you use ultrasound on babies. And in the end, we pretty much figured out there really aren't any bioeffects when we use ultrasound. The AIUM has also put out a statement regarding cavitation and the chances of it happening within the body when we use diagnostic ultrasound. And basically what it found was that there were no cavitation within the blood cells of mice in the laboratory, and that in vitro studies did show that we could get cavitation, but the in vivo studies did not show any sort of cavitation. So in the end, the AIUM kind of took a look at all the studies that were out there and have created their own conclusions. As sonography professionals, we typically do align with the AIUM. Granted, you can have your own opinion on the things as well, but for educating the general public, we always go back to what the AIUM has kind of concluded and set out standards for us. So the AIUM has concluded that no, there are no confirmed harmful bioeffects from exposure to diagnostic ultrasound. We recognize that it is possible for bioeffects to occur and that they may be identified in the future. We also recognize, again, that the benefit to the patient is going to outweigh the risk to have an ultrasound done. The fourth conclusion is that we believe that it is appropriate to use diagnostic ultrasound prudently and to provide benefit to the patient. And number 5, that it is inappropriate to use diagnostic ultrasound in a non-medical setting for entertainment. So they have decided that boutique type fetal imaging places are maybe not the appropriate use for ultrasound, as those are less monitored and regulated than diagnostic laboratories are. And this is just another statement from the AIUM, again stating that there is more benefit to using ultrasound to image a fetus to look for fetal defects than there are risks to mother or fetus. So to make sure that we are keeping a professional standard and not posing more risks to our patients, the IUM suggests that we are not going to perform any studies without a reason, that we are not going to do prolonged studies and minimize the exposure time, that we are going to use the minimum output power and the highest receiver gain to produce good images. So that goes back to the ALARA principle, as low as reasonably achievable. And that whenever we are doing studies, we recognize that the potential benefits should always outweigh the risks. So with that being said, you guys are scanned day in and day out for educational purposes. There really are no bioeffects that have been reported. Only in vitro studies and computer modeling have they figured out that if you kept an ultrasound probe 24 hours a day in the same spot, you might start to get enough heat in the tissue that something might happen. But that's just not what we do. We're constantly moving. We are never holding our transducer in the same spot for that long. So we recognize that there is no bioeffects in day-to-day use of ultrasound. You guys are also getting the benefit of learning ultrasound, and that is going to outweigh the risk of any bioeffects that may be occurring. So in the end, your role as a sonographer and keeping people safe with the bioeffects, remember ALARA, and we need to be prudent, careful, and judicious when we are using ultrasound, and as always, just be an ultrasound professional. All right, so kind of an interesting chapter in that we don't necessarily think of the bioeffects that might be occurring as we are doing ultrasounds on patients, but it is still important to kind of keep in the back of your mind. So with this chapter, make sure to know those 6 devices. Make sure you know what they are, what they do, how they measure intensities or heat within the ultrasound beam. If you can kind of make a chart of them and recognize what they each do, that'll be helpful for you. Also know in vivo versus in vitro. Know empirical versus mechanistic approaches. Also know the role of mechanical index and thermal index and how we monitor those. And then understand what our role is as sonographers in keeping people safe with ultrasound. Let's go ahead and test yourself. Number 1, list and define the 6 instruments used to test ultrasound beams. Number 2, what does in vivo and in vitro testing mean? Number 3, what are mechanistic and empirical approaches to looking at data? Number 4, why do we monitor the thermal index? Number 5, why do we monitor the mechanical index? Number 6, what are your thoughts on the AIUM's position and suggestions? And number 7, what questions do you have about this lecture?